The Acumed Locking Clavicle Plate System is an extensive collection of 31 plates to address comminuted fractures, malunions, and non-unions. To treat complex lateral third clavicle fractures, Acumed's locking distal clavicle plates are available in a variety of lengths and include 3, 4, and 8-hole distal options to precisely target fragments and provide stable fixation for a wide range of fracture patterns. Please refer to the product brochure for a complete description of the surgical technique and range of options available for radiographic evaluation. This surgical technique will illustrate the use of the locking distal clavicle plate incorporating 2.3 mm screws in the lateral flare. After completion of a thorough radiographic evaluation, the patient is placed in a beach chair position with the head rotated and tilted 5 to 10 degrees away from the operative side. A bolster is placed between the shoulder blades and head, allowing the injured shoulder girdle to retract posteriorly. This will facilitate reduction by bringing the clavicle anterior to restore length and improve exposure. Surgeons may choose one of 2 incisions. Option 1. A 3 cm to 5 cm transverse infraclavicular incision is made parallel to the long axis of the clavicle so that the scar does not lie over the plate. This approach provides convenient, unlimited access to the entire length of the bone. Option 2, an incision along Langer's lines running perpendicular to the long axis, provides better cosmetic results and less damage to the supraclavicular cutaneous nerves. It is important to keep soft tissue attachments to the butterfly fragments in an attempt to maintain vascularity. Select the appropriately sized locking distal clavicle plate from the different lengths and curvatures in the system. The curve of the plate may assist in anatomic reduction of the clavicle, reducing strain on the sternoclavicular and acromioclavicular joints. Lag screws may be used for interfragmentary fixation. Many type 2B clavicle fractures have a horizontal cleavage fracture that extends into the AC joint, which may be fixed in this manner. Once the plate's ideal positioning has been selected, it is provisionally stabilized to the clavicle with plate tacks or plate clamps. To ensure that the plate does not infringe upon the AC joint, under radiographic evaluation, place a K-wire through the designated K-wire hole at the far distal end of the plate. Non-locking screws may be placed either unicortical or bicortical. It is important not to over-penetrate the inferior cortex and potentially risk neurovascular injury. The clavicle retractor should be placed under the inferior surface of the clavicle to protect the neurovascular structures from over-penetration of the drill bit. Replace drill if it comes in contact with clavicle retractor. For early stability, the first 2 3.5 mm screws placed should be medial to the fracture site. Once 2 screws are installed, the plate tacks or bone clamps holding the plate to the clavicle may be removed. Tapping is recommended for patients with dense bone. Before placing the targeting guide on the plate, secure the plate laterally to the distal fragment by inserting a 2.3 mm non-locking screw through the medial most center hole. Slide the appropriate targeting guide over the K-wire and down to the plate. The targeting guides are color-coded, blue and green, to match the corresponding left, blue, and right, green plates. The correct positioning of the targeting guide is achieved when the 2 pins on the bottom surface of the targeting guide engage the 2 suture holes just proximal to the distal screw holes. The targeting guide must sit flush against the plate for proper functionality. For the distal holes, place the 2.0 mm locking drill guide into the desired hole and turn clockwise so that the guide fully threads into the plate. This will hold the targeting guide flush to the plate. Insert the 2.0 mm drill and advance to the desired depth. Drill depth is determined by referencing where the laser mark on the drill aligns with the measurement on the 2.0 mm locking drill guide. When between sizes, choose the shorter screw option. Remove the locking drill guide and insert the proper length of screw through the targeting guide. Advance the screw until the screw head fully engages the plate. Repeat these steps until a minimum of 6 screws have been fully inserted into the plate and bone. For the shaft portion of the plate, use the 3.5 mm locking drill guide and the 2.8 mm drill to replace the 3.5 mm locking and non-locking screws. An intraoperative radiograph is recommended to check the position of the screws and the final reduction of the fracture. If the bone quality of the lateral fragment is poor, sutures may be passed from medial to lateral around the coracoid and through the suture holes in the distal portion of the plate to take stress off the lateral fixation. After radiographic evaluation and routine irrigation, the trapezial deltoid fascia is closed over the clavicle and AC joint, followed by closure of the subcutaneous tissue and skin.